So hi everyone, this is our second sessions, hand injuries. Now moving to the next fracture, mallet finger. The mallet finger is an avulsion injury of the extensor tendon at the distal phalanges. Tendon involved in the extensor digitorum insertions. It occurs when the forceful flexion happens on the extended fingers. Since the extensor tendon is disturbed, the DAP joint drops. The flexor tendon acts as unopposed structure. If untreated. If it is untreated, it may lead to swan neck deformity. The management is continues as the distal interphalangeal extension splinting for 6 to 8 weeks. So the mallet fingers have been ruptured of uh, extensor digitorum tendon. It may, if it remains untreated, the swan neck deformity will occur. So, what are the managements? Splinting is the most important management for this type of injury. The important point of the mallet finger is every one movement of flexion during the treatment can be disturbed healing. Uh, this is the tendon healing. It requires strict compliance. That means we should not move or we should not do any function of this DAP joints while the healing occurs. Still, the healing occurs. So, coming to the next fingers, it is also an uh, avulsion type of fracture, which means the Jersey fingers. It is an avulsion of flexor digitorum profundus tendon. That the mallet fingers, it is on the extensor digitorum profundus tendon, and the Jersey fingers is on flexor digitorum profundus tendon. It occurs when player holds an object and finger is forcefully extended while playing the carom as like that. So the patient cannot be flexed DAP joint tendon reacts proximally. It because it reacts conservative treatment will not be work. Therefore, the early surgical repair is mandatory. Delay leads to permanent loss of DAP flexion. We cannot flexion the joint. The comparison of both avulsion type fractures. The mallet fingers need splint and Jersey fingers need surgery. Then phalangeal shaft fracture. The phalangeal shaft fracture is influenced by intrinsic muscle pull. The introsi and lumbricals causes the angulation and rotation of this fracture. The most dangerous deformity are rotational type deformity. How we can check? Ask the patient to make fist. If the fingers overlap, the rotation is present. If the finger is overlapped, then the rotation is present. The management includes reduction and splinting. It means the phalangeal shaft occurs, then the management should be include reduction and splinting. The caver fixation if it is unstable fracture. The alignment must be restored for proper grip strengthening function so that we can able to gripping the objects and etc. Then coming to the distal phalanges or crust type fractures. These fractures are commonly in door crust injury. They are often associated with nail bed injury. The risk include infection and the nailing deformity. The what is the nail bed repair? It is an fracture associated type of management. That means a point of thin metal uh, type of substance that will be incorporated to the bone to repair and fracture. Then the another management is to splinting. The aim is to restore the grip, fingertip grip, and continue to prevent the chronic pain of these joints. So, end of the session of second. Next, we move on to scaphoid and rest of the fractures of the hand. While occurring the phalangeal shaft fracture, we should check pre and post fractures of this. So the metacarpal fracture, the distals and head of metacarpal fracture, etc. Thank you.